Hello students. So today we'll be discussing on different classes of antibiotics. First we'll start with a silent prayer. So we have discussed already some groups of antibiotics. So today's session we'll be discussing on cephalosporins and aminoglycosides. Okay. So first we'll discuss about cephalosporins. So you have already learned about beta-lactam antibiotics and which are the drugs that come under beta-lactam antibiotics. So which is the most important drug that come under beta-lactam antibiotics? That is your penicillins, right? And other beta-lactam antibiotics include cephalosporins, monobactams and carbapenems. So you have seen about penicillins, monobactams and carbapenems in the last classes. So this class will learn about cephalosporins. So why are they all called beta-lactam? Because you can see here there is a common beta-lactam ring in all their structure. And you know, cephalosporins is one of the most common antibiotic that is being prescribed both outpatient and inpatient category. Now, what is the mechanism of action of cephalosporins? It is same as that of penicillin. So what do? They inhibit the cell wall synthesis. So this is a bacterial cell wall that is unique to the bacteria. It is made up of peptidoglycan units. So each peptidoglycan has got an N-acetylmuramic acid and N-acetylglucosamine, and onto this N-acetylmuramic acid there is a pentapeptide chain that is present, and there is cross linking between this peptidoglycan structures that gives the stability to the bacterial cell wall. So what do they do? Cephalosporins and other penicillins do, they bind with this penicillin binding proteins which are known as transpeptidase enzyme, and they inhibit the transpeptidation reaction. This transpeptidation reaction is essential for cross-linking between the peptidoglycan chains. So this is one peptidoglycan chain, this is another peptidoglycan chain. So in order to bring this cross-linking, that is with the help of a reaction known as transpeptidation reaction, which is done with the help of transpeptidase enzyme or penicillin binding proteins. Another name for transpeptidase enzyme is penicillin binding protein. So these drugs, cephalosporins and penicillins, they bind with this penicillin binding proteins or transpeptidase enzyme and inhibits the transpeptidation, so that the cross linking is not taking place. So what happens if there is no cross linking? You get a cell wall which is weak, okay, and that results in structural irregularities leading to cell lysis. Okay. Now, any mechanism of action, if you know, you automatically can understand what is a mechanism of resistance. What is meant by this mechanism of resistance? The mechanism by which the bacteria attains resistance to this antibiotic. So, for any bacteria, either what does it do? It does not allow the antibiotic to get inside the bacteria, okay, or it can inactivate the bacteria with the help of inactivating enzymes, or it can pump out the antibiotic from the bacterial cell, or it can alter the target protein. So these are the different mechanisms by which the bacteria attains resistance to the antibiotic. For each bacteria, to each antibiotic, there will be one most common form of development of resistance. So in case of beta-lactam antibiotics, be it penicillins or cephalosporins, the most common mechanism of resistance is formation of beta-lactamases. The bacteria will produce this beta-lactamases enzyme that will hydrolyze the beta-lactam ring. You can see here, this is the beta-lactamase enzyme that will come and lyse this beta-lactam ring, so that the antibiotic cannot come and bind with the penicillin binding protein or the transpeptidase enzyme. So that is the most common mechanism of resistance for beta-lactam antibiotics. There are other mechanisms like it causes reduced drug permeability to reach this penicillin binding proteins by altering the porin channels, or by antibiotic efflux mechanisms, or by altered penicillin binding protein. These are all the mechanisms of resistance, but the most important is hydrolysis of the beta-lactam ring by beta-lactamases. Now we come to the classification of cephalosporins. You have from 1 to 4 generations. Actually now there is a 5th generation also. This is based on the development which was developed first and based on their antimicrobial activity. So you have first generation, you have cefazolin, cephalexin, and that is mainly active against gram positive organisms like streptococci and staph aureus. Second generation, you have more activity against gram negative, and some of them are active against anaerobes. So you have cefuroxime, cefaclor, cefoxitin, cefotetan. So these are active against gram negative organisms like E. coli, Klebsiella, Proteus, H. influenza and all. Cefoxitin, cefotetan are active against anaerobes like Bacteroid fragilis. Then we come to the third generation, which is very widely used. You have cefotaxime, ceftriaxone, cefixime, ceftazidime and all that are most active against gram negative. Some of them like ceftazidime, cefaperazone are active against pseudomonas also. Fourth generation, you have cefepime and cefpirom. That is like an extended spectrum of third generation. They are active against gram positive, gram negative plus pseudomonas. So don't get hassled by all these names. Keep on repeatedly reading this and revising these names, and try to learn at least 2 examples from each generation. And remember, first generation is gram positive, second generation is mainly gram negative, and few are active against anaerobes. Third is mainly gram negative and some are active against pseudomonas. Fourth is again gram positive, gram negative and pseudomonas. And most importantly, when you come to the resistance, as we come from first generation, they are highly susceptible to hydrolysis by beta lactamases. As we come to fourth generation, they become more and more resistant to hydrolysis by beta lactamases. So you can give this fourth generation agents for the resistant organisms. Okay. So don't be in this situation after this classification. We'll discuss each of these generations once more and you'll get a better idea. So first we come to first generation. First generation, you can again divide them as those which we can give orally and those which we can give parentally. So learn one example. In oral, remember cefalexin or cefadroxil, whichever is easy for you, and make this classification, write it in a paper and stick it in your room and read it every day so that you by heart it. Parental, remember only one agent, cefazolin. Okay, so which are the group of organisms against which it is maximally active? It's active against gram positive organisms, not much active against gram negative, and they are highly susceptible to hydrolysis by beta lactamases. And all these agents are excreted by kidney, and first generation they do not cross the blood-brain barrier, so you cannot give them in meningitis. The main use of first generation is cefazolin we use for surgical prophylaxis. That is, if you are planning for a elective surgery, clean procedure, you give cefazolin half an hour before surgery. You prefer cefazolin because of its long duration and high tissue penetration, and you give it half an hour before surgery so that maximum concentration is attained in the skin at the time of skin incision, so that you prevent a post-op infection. Other agents like cephalexin, cefadroxil and all, you give it for mild skin soft tissue infections like any abscess, uncomplicated UTI or upper respiratory infection like sinusitis. Now we come to second generation. Second generation, again remember any one oral and one parenteral. If you remember cefuroxime can be given both orally and parentally. Orally you give it as a prodrug, cefuroxime acetyl. Parentally you give cefuroxime. Then you have cefoxitin, cefotetan, which I have told earlier, which is active against anaerobic organisms. Okay, so which are second generation most active against? Mainly gram negative, and cefoxitin, cefotetan are active against anaerobes. Okay, even though they are active against gram negative, their activity is less compared with that of third generation cephalosporins. They are partly resistant to production of beta lactamases. Cefoxitin, cefotetan are active against anaerobes. So where do we use these agents where we require anaerobic coverage? like that of colorectal surgeries, anything with to do with abdomen, intra-abdominal infections, pelvic inflammatory disease, diabetic foot and all, where we suspect anaerobic infection, you can give these agents, cefoxitin, cefotritan, for anaerobic coverage. Other than that, we use it for uncomplicated UTI and URTI, these agents, cefaclor, cefuroxime, acetyl and all. Cefuroxime, another advantage of cefuroxime is it can be given both orally and by injection. It can cross the blood-brain barrier, so you can give it in meningitis, but you prefer third generation cephalosporins rather than cefuroxime for conditions like meningitis. So next we come to third generation, very important, very widely used. Every third person you will be seeing in a medicine ward will be getting one of these cephalosporins. So again, you have oral and parenteral. Parenteral, I think you will be familiar with the drug names ceftriaxone, cefotaxime, ceftazidime, cephalosporins and all. And it is important to know which are the oral agents under this class, because in the hospital we will be administering them parenteral, and when we are discharging we give them oral antibiotics for 5 more days. So you need to know which are the oral drugs available in this class. You have cefixime, easy to remember, cefdinir, okay, any one name at least you remember. Parenteral, remember cefotaxime, ceftriaxone. So they, the spectrum, they are highly active against gram negative. Also ceftazidime, cephalosporins are active against pseudomonas. They are having good resistance to beta lactamases hydrolysis. And among these agents, there is a peculiarity for ceftriaxone. All other agents are having a half-life about 1.5 to 2 hours, whereas ceftriaxone has got a long half-life of 8 hours. So you can give it once daily or twice daily. And another advantage of ceftriaxone is it can cross the blood-brain barrier, so you can give it in meningitis. Okay. And cephalosporins, ceftriaxone, another thing is most of the cephalosporins are excreted through kidney, so you require dose reduction in renal failure, except cephalosporins and ceftriaxone, which are excreted through bile, so there is no dose reduction required in renal failure, or you can give it safely in renal failure. So what are the uses of third generation? We use it for conditions like serious infections caused by gram-negative infections like meningitis, except that produced due to listeria, because cephalosporins do not have any activity against listeria. You give it for community-acquired pneumonia caused by pneumococci, H. influenza, or even Staph aureus, complicated UTI, abdominal sepsis, septicemias, typhoid. It is an alternative to ciprofloxacin. Gonorrhea, ceftriaxone is a drug of choice. And ceftazidime, which is anti-pseudomonal action, it is activity against pseudomonas, so you combine it with aminoglycoside for pseudomonas induced meningitis. Also in case of febrile neutropenic patients where the neutrophil count is very low and the patient is having fever, or in burns patient where you suspect there is a chance for pseudomonal infection, you give them a combination of ceftazidime and aminoglycoside. We'll see about aminoglycoside in the next session. It is another agent that is having good activity against pseudomonas. Fourth generation, easy to remember, only 2 drugs and both are given parenterally. Both are having a PI in their name, cefepime and cefpirone. Okay, so it is an extended spectrum and has high activity against pseudomonas and enterobacteria. Important thing is it has increased ability against beta lactamases, so you can give it in resistant infections caused by resistant strains. It will be active and it has good penetration to CSF, so you can give it in meningitis also. So you give it for nosocomial infections, for pneumonia, febrile neutropenia, septicemia, complicated UTIs like pyelonephritis and other complicated intra-abdominal infections. So now we have seen the different generations of cephalosporins. We have seen first generation, second generation, third generation, fourth generation, where we use these agents, what are the bacterial spectra against which they are active against. Any antibiotic, which are the headings which you should write? You should write the examples. If any classification, you should write mechanism of action, spectrum, uses, and finally adverse effects. So now we'll see the adverse effects. So these antibiotics, any antibiotics have allergic reactions as a side effect, hypersensitivity reactions. It is more common for cephalosporins, and whenever you're injecting, there is local chance for thrombophlebitis and pain at the injection site. Hypersensitivity is very common, and you should always note that you should give it slow IV push, and do not just push the antibiotic, so that if you're giving it by slow IV over a 5 minutes, if the patient is developing any adverse like rashes, itching and all, they can immediately stop it, rather than giving it as fast IV and patient going in for a cardiac arrest. There has been incidences, we have got reports of severe ADRs like cardiac arrest, which requires resuscitation with ceftriaxone injection and all. So always do a test dose before you inject, plus give it slow IV, don't give a fast push. And maculopapular rash sometimes develops even many days after therapy, and since they all have this beta-lactam ring in them, there has been cross sensitivity with penicillins. 20% chance that a person who has allergy to penicillins develop allergic to cephalosporins also. And nephrotoxicity, this is not seen with this newer cephalosporins. With earlier cephalosporins like cephaloridin, cephalothrin and all, nephrotoxicity like acute tubular necrosis is seen. You need not remember these drug names, just write nephrotoxicity is seen with certain cephalosporins, that much is enough. Diarrhea is seen with cephalosporin. I've told cephalosporin and ceftriaxone are two agents that are excreted through bile, and since it is excreted through bile, there is chance for diarrhea with cephalosporin. Ceftazidime, which is an anti-pseudomonal cephalosporin, is shown to have decreased neutrophil count. And certain cephalosporins, need not remember the examples, just for your understanding I've put it. They have got a group in them known as methyl thiotetrazole group, and these cephalosporins exhibit disulfiram like reaction with alcohol. Disulfiram is otherwise known as NWs, which we give for alcohol patients who are dependent on alcohol, to reduce their dependence on alcohol. What disulfiram do is, it is an enzyme that it is a drug that inhibits aldehyde dehydrogenase enzyme, and as a result the aldehyde levels is accumulated in the body, and the patient, when they consume alcohol, this aldehyde level will be more, and the patient will have symptoms like chest pain, palpitation, suffocation. The patient feels as if he is going to die, and that helps to keep him motivated to avoid drinking. We don't give it for physically dependent patients on alcohol, but those who are highly motivated, if they want to quit alcohol drinking habit, this helps in keeping their motivation strong. So certain antibiotics like metronidazole and certain cephalosporins, when they take, they may exhibit disulfiram like reaction. So you should advise, if they are on these antibiotics, that they should not consume alcohol. And sometimes they may show severe bleeding, especially hypoprothrombinemia. This is seen with these group of cephalosporins as well as with ceftriaxone. Okay. These are the hypersensitivity reactions that are seen due to cephalosporins. And just like penicillins, you also combine the cephalosporins with beta-lactamases inhibitors like clavinalic acid, sulbactam, tazobactam and all. Why? Because you can restore the spectrum for previously sensitive organisms who have developed resistance by forming this beta-lactamase enzyme. By combining with this beta-lactamase inhibitors, you can restore the spectrum, plus you can enhance the spectrum, which includes organisms which were not sensitive earlier. Example of combinations are cefotaxime plus sulbactam, ceftriaxone plus tazobactam, etc. Okay, so that much is about cephalosporins. Should know the classification with examples, 2 examples in each class. Then you should know the mechanism of action, that is cell wall synthesis inhibitor by combining with transpeptidase or penicillin binding proteins. Mechanism of resistance is by exhibiting beta-lactamase enzyme. And then we have seen the uses of each of these generations. First generation cefazolin remembers for surgical prophylaxis. Second generation mainly remember the anaerobic coverage by cephalosporins, cephalosporin. Third generation has numerous gram-negative infections including typhoid, meningitis, pneumonia, etc., complicated UTI and all. Fourth generation have all these activity against this resistant infections by resistant strains as well as against pseudomonas. Then we have seen the adverse effects and the combination with beta-lactamase inhibitors. Clear? If you want, you can take a break and come back and listen to the next antibiotic, that is aminoglycoside. So why is it called aminoglycoside? You can see it has amino sugars that is linked by glycosidic linkages. So they are all obtained from soil actinomyces. You have streptomycin. Examples are very important. Streptomycin, kanamycin, tobramycin, neomycin, gentamicin, amikacin. Why the spelling difference MYCIN and MICIN? Based on which actinomycetes it is derived from. If it is from streptomyces, the name ends with MYCIN. If it is derived from Micromonospora, it ends with MICIN. Now, what is the mechanism of action of these agents? They are protein synthesis inhibitors. They bind with 30S and they inhibit the protein synthesis. Usually those drugs that inhibit the protein synthesis are bacteriostatic. That means they do not kill the bacteria, they arrest the growth of the bacteria because they inhibit the protein synthesis. One exception for this is aminoglycosides. Even though they inhibit protein synthesis, they are bactericidal agents. You can see here, this is how there is a 30S ribosome, there is a 50S ribosome, mRNA lies in between. The first step in protein synthesis is formation of the initiation complex that is inhibited by aminoglycosides. So aminoglycosides, they bind with the 30S, they inhibit the initiation complex formation that results in misreading of mRNA and formation of abnormal proteins. Remember, the spectrum for aminoglycoside is aerobic gram-negative organisms. All the words are important. Aerobic, gram-negative. Why aerobic? Because it requires an aerobic transporter to transport the aminoglycoside into the cell, and it is active only against gram-negative organisms like E. coli, Proteus, Pseudomonas, Salmonella, Shigella, etc. And they are more active at alkaline pH. And all these aminoglycosides have some common properties. So we'll see the common properties first. Just a word about mechanism of resistance. As I told earlier, any antibiotic, how do they develop? They can either inhibit the entry of the antibiotic to the cell, or it can alter the target site, or it can inactivate the drug, or it can pump out the antibiotic from the cell. And for each bacteria, against each antibiotic, there will be one mechanism that is more predominant. What was the predominant mechanism of resistance in case of penicillins or cephalosporins? It is by inactivating enzymes. That is, they produce beta-lactamases that inactivate the drug. Similarly, for aminoglycoside also, the inactivating enzyme is a major mechanism of resistance. The bacteria produce enzymes that inactivate the drug. Other mechanisms are also there, that is decreased affinity to the ribosomal proteins and altered ribosomal proteins, and decreased efficacy of the transport protein that transports the aminoglycoside into the cell. Now we come to the common properties. So all these agents are bactericidal. They come and bind with 30S and inhibit the protein synthesis. Another property is they are highly polar and ionized, because of which you cannot give them. All our membranes, GI membrane, blood membrane, all are highly lipid soluble. So aminoglycosides, since they are highly polar, it is highly water soluble. So even if you give orally, it won't be able to get absorbed. So you have to give them parenterally. Another property which they exhibit is concentration dependent killing. That is, higher the concentration, higher the initial amount of the bacteria, greater is the rate at which the bacteria are killed. So what you do is, instead, for certain antibiotics like penicillins and all, it depends upon how much time the antibiotic is remaining above the minimum inhibitory concentration. For them, you have to give it every 8th hourly. You give it 3 times a day, so that the antibiotic concentration is remaining above the minimum inhibitory concentration. But for certain antibiotics like aminoglycoside, fluoroquinolones and all, it is a ratio. That is, if you give higher concentration initially itself, it is able to kill the bacteria at a higher rate. So you prefer giving these agents as a single dose rather than giving it 3 times or 4 times daily, so that you can reduce the side effects. And it shows post antibiotic effect. That is, even after the drug is eliminated from the body, the antibiotic effect, that is the growth of the, how do we determine the post antibiotic effect? You have seen in microbiology the culture plates. Even after the antibiotic is remaining or removed from the body, there is a zone of inhibition seen around the bacteria. That is, even after the antibiotic is not there in the body, the growth of the bacteria remains suppressed. And because of this property, you can give aminoglycosides once daily also. And this I've already told, all these agents are highly polar and ionized, so there is no oral absorption, as well as the CSF entry is minimal. And they are all excreted through kidney, so you have to reduce the dose in renal failure. And they have common shared toxicity. All the aminoglycoside shows 3 toxicity: ototoxicity, nephrotoxicity and neuromuscular blockade, and they all have narrow safety margin. There is high chance for them going for toxicity. So these are the common shared toxicity. It can cause ototoxicity, that is manifested as either tinnitus, that is a ringing sound in the ear, or deafness which can be permanent, and vestibular toxicity manifests as nystagmus, vomiting, nausea and all. It can cause nephrotoxicity, kidney damage, so you should be very careful, and you should not administer other nephrotoxic agents to the patients like vancomycin, cephalosporin, etc. And also be careful when you administer other ototoxic agents like furosemide, ethacrynic acid and all. And it can produce neuromuscular blockade that manifests as paralysis. So where do we use them? If you remember the spectrum, you will be able to remember the uses. Gram-negative infections. Okay, so you give it for UTI, pneumonia, osteomyelitis, meningitis, septicemia, etc. that is caused by gram-negative organisms. Meningitis, even though it doesn't cross the blood-brain barrier, if you combine it with cell wall synthesis inhibitors, then it can penetrate. Then in subacute bacterial endocarditis, you give it along with penicillin. For TB, tuberculosis, plague, tularemia, brucellosis, streptomycin is given along with tetracyclines. Topically, you can administer these agents for skin infections, burns, eye and ear infections. And even though we say you cannot administer these agents orally, you have oral neomycin. So where do we use oral neomycin? Oral neomycin does not get absorbed, so it will directly reach the colon and it will kill the colonic bacteria there. So we use it for pre-operative gut sterilization. Another use where we give oral neomycin is for hepatic coma. Hepatic coma is, or hepatic encephalopathy, is because of increased ammonia production. So what does this neomycin do is, it kills a colonic bacteria that will otherwise produce ammonia, and that can worsen the hepatic encephalopathy. So neosporin, by killing the colonic bacteria, reduces the production of ammonia and thereby useful in hepatic coma. Coming to nursing implications, always remember you should not mix aminoglycoside with any other drug like penicillin and all. Give them in 2 separate syringes. Never mix them in same syringe, that can lead to precipitation. And since these agents are highly ototoxic and nephrotoxic, you should not combine with other ototoxic drugs or other nephrotoxic drugs. And always look out for the renal function, especially in elderly, because they are more prone for development of nephrotoxicity, and they are contraindicated in pregnancy because of risk of ototoxicity in the child. These are the important nursing implications. So you remember the examples: mechanisms by inhibiting protein synthesis, by inhibiting the initiation, but they are bactericidal. And then we have seen the spectrum: aerobic gram-negative organisms. We have seen the uses and adverse effects: ototoxicity, nephrotoxicity, and neuromuscular blockade, and what are the nursing implications. So that is for today's class. Hope you understood, and thank you for listening. Please do message if you have any doubts.